Next, we welcome Professor Sobha Sivaprasad, Professor of Retinal Clinical Research at University College London, and also an awardee of the Ophthalmologist Power 100. She will speak on diabetic neuro-Glia-Vasculopathy. Please welcome Professor Sobha Sivaprasad.
Thank you very much. And I would like to thank Professor Dennis Lam for inviting me for this professorship here. So it's a great opportunity for me to give my lecture today. You will wonder why I'm coming up with a boring subject called diabetic retina glial vasculopathy. I thought I would take this opportunity to see how we could disrupt our idea about diabetic retinopathy. These are my disclosures. So diabetic retinopathy has always been considered a microvascular disease, and I'm sure we all do our screening, our management, all based on microvascular lesions we see on a daily practice on the retina. So my big question is, over 150 years ago, the brain professors have all taught us the concept of neurovascular coupling in the brain. The retina is, of course, just an outpouch of the brain, and yet we have never applied any of this in any of our classification system or management systems to date. So we have very good imaging systems now and functional test. So there is no way in a sandwiched retina layers like this with microvascular in between, we can't imagine that diabetes only affects the microvasculature. Clearly, all the retinal neurons and glia are also affected, but we never take care of it. So I want to take a few moments to go through the review of literature of why we should change our mind. We have a lot of laboratory science, very good studies that show cell-to-cell interactions of glia and neurons with the microvasculature. And this is a very good review article by Alan Stitt's group that shows us that microvascular cannot answer all our questions. For example, when you come to the neurons, we have enough and more evidence to state that the ganglion cell layer and the photoreceptors are affected very early on, even before the appearance of microvascular lesions. And here, this review article shows the rest of the neurons, the amacrine, the horizontal cells, the bipolar cells, are all affected. And indeed, it also can produce the VEGF that we are talking about day in and day out, and trying to treat the VEGF, but not the primary source of the pathology. So let's go on to neuronal cells. So when you talk about, or have you got any clinical evidence that these neurons may be affected? Of course, we have a lot of data on functional changes that occur in people with diabetes before the onset of microvascular lesion. And there's also articles that suggest oxygen therapy can reverse contrast sensitivity impairment even before microvascular changes. So clearly, it shows that hypoxia occurs early, and there is something else driving it. We know from Prof. Arden's theory for about 30 years, he worked on the concept that rod photoreceptors use up all the oxygen and cause the retina to be a relative hypoxic area, and therefore the rod photoreceptors may trigger diabetic retinopathy changes. I have tried to work with him and investigated it, but I don't think it is sufficient. We as a community need to think differently about what causes microvascular changes in the retina. We also have, coming into the glia, you can see here the green color is the Muller cells that surround the microvasculature. Clearly, the microvasculature alone cannot get involved with the independent Muller cell just around it like this. It also has certain gaps where you see the astrocytes in yellow affecting the microvasculature. So clearly this shows the glia are also affected. There are differences between the astrocytes and the Muller cells. So the astrocytes are mainly in the superficial retina. So that can explain the vascular leakage we see very early. And it affects the ganglion cell layer. And therefore, we know thinning of ganglion cell layer occur even before retinal vascular changes. So these are laboratory science experiments that have already told us, but we have never included any of these findings in any classification system. When you come to Muller cell, it's even a bigger representation in the retina. It covers the whole length of the retina, and it's not only a structural support, and it can explain several of our functional deficit we see despite anti-VEGF treatment. We know about neurodegeneration. Muller cell may have a place, gliosis due to Muller cells, and also electrophysiological changes. Here you can see Muller cell changes triggered by early stressors of diabetes, including metabolic as well as oxidative stress. And you can see on the middle column all the laboratory evidence as to why Muller cells are affected, not only early in the disease, but through the course of a person with diabetes. It can cause gliosis, as I explained earlier. It can cause lack of support, and therefore I will show you a few images later on to suggest how the support can collapse. It causes loss of potassium, glutamate excitotoxicity. Swelling of the Muller cells may be a cause of extracellular edema that you see. We call them extracellular. They may be intracellular Muller cell edema, which has not been investigated well clinically. And these have all risen, causing VEGF increase, which causes leakage. It can cause blood-retinal barrier breakdown. It can cause inflammation through microglial activation. Again, I just want to stress, we have never thought of any other things except trying to treat microvasculature. This is another review article that shows us how the macular edema is represented in the retina. I don't believe anti-VEGF treatment drying up that macular cyst you see will give us perfect vision. We all know in our clinic, significant number of patients do not improve vision despite anti-VEGF treatment drying up the macula. So anti-VEGF does not restore Muller cell metabolism or the neurotropic function that the Muller cells have. So again, leading us away to rethink what we are doing today. This is an example from Prof. Marshall on histopathology of how the Muller cells are like when there is intraretinal cystoid edema. And you can see the representation of the Muller cells. They're actually transmitting synaptic transmission across the retina. And we do not pay attention. When you see a big cyst, you just think, oh, the cyst isn't working. But we don't think of the perimeter of the cyst, which contains the glia and the neurons. Neurodegeneration also occurs as a result of microvascular changes. Again, we know about drill, we know about EZ loss, etc. in the imaging. We don't seem to want to accumulate all this evidence and come up with a better way of understanding diabetic retinopathy. Microglial activation is very important. We have always thought of microvascular disease in diabetes may have an inflammatory component. We are giving steroids to a lot of our patients, but we never once think what microglia can do to the retina, can amplify the metabolic stress, it can mediate the neurovascular decoupling, and also is a sustained effect of chronic inflammation. So with the availability of OCT, with the availability of OCTA, we can now go layer by layer of the retina, looking at the neurons and the color photograph of microvasculature, and then align them together. And clearly it shows, okay, if you have superficial leakage, the astrocytes may be involved, the ganglion cell may be involved. If it's a middle layer, then you think of the bipolar cells. Outer, we all talk about deep plexus being involved early. Try and relate it to the photoreceptors. That mindset hasn't come to us, and I take this opportunity to let everyone know, let's think about it differently. Of course, all these are biologically plausible, but we as a community haven't been able to treat either the neuronal part or the glial component as yet. So we have several markers of oxidative stress, drugs involved in that have all been trialed, but hasn't worked. That shouldn't discourage us from reclassifying diabetic retinopathy. So in conclusion, what I'm trying to say is diabetic retinopathy classification based on microvasculature is a gone past story. We as a community, especially in Asia, where the the maximum number of people with diabetes is living, should take the initiatives to run some large collaborative grants. And I applaud what Christopher Leung just mentioned about Hong Kong. You can see all the imaging, all the visual function, and that's exactly what we need from China and perhaps India as well, because they can teach the developed countries like Europe or US about what actually happens to minor ethnic groups, because we are the ones who are most affected by diabetes. We also have to identify DR phenotypes. And again, I applaud Chris for his epidemiological study, because it gives you so much of structure function relationship that we could do, especially with the availability of AI these days. So with that, I think we also I definitely like to see a lot of clinical trials and new endpoints from Asia. Thank you very much.